people, who knows when they ovulate?
Really random.
Yeah.
It'll like pop.
Right. Now, so you may have a big, like if you're rupturing a big cyst, you'll feel it, okay? But most of the time that stuff is microscopic, and so you're not going to feel it. Now, some women will see changes in their libido throughout their cycle. Like, we're back to this backup system, like we are animals who are trying to procreate and potentiate our species. It is natural to have an increase in libido when you ovulate because you're trying to get yourself knocked up. It's just your instinct. I mean, just your instinct to procreate and continue the species. And so if you're not on birth control pills. If you're on birth control pills, you're suppressing all that. You're suppressing that normal feeling from the hormone because you aren't having that LH surge. Okay? So most women don't complain about them, except to their best friend or their spouse. Okay? Now, again, I like to mix and mingle with men as much as I do women because I don't particularly like to sit around and talk about it. But some women like to gather at their girlfriend's house and have tea parties and breakfast clubs and talk about their pregnancies and their menstruation and things like that. It's not my thing. But, so most people don't complain about it. It's just a part of what we have to do, right? You just deal with it. Most symptoms resolve within 4 days of the period starting. Some people resolve the day they start menstruating. They're like, thank God, I feel so much better already. So, again, the estrogen drops off, the progesterone drops off, so you have this big, the door shuts, this big change in your hormones. You also have the renin-angiotensin system activated, so you get the weight gain, the fluid retention, which makes you bloat. Fingers get tight, rings get tight, things like that. There are I'm not kidding you, at the 400 different symptoms of PMS that people have connected with PMS, but your big ones are going to be bloat, weight gain, cranky, breast tenderness, things like that. Yes?
Why is the renin-angiotensin, why is that activated?
Just the hormones, okay? You don't need to know pathophys, okay? It activates that system. It's a great question I wish I could answer. I'll answer it for next year's class. Okay, so we have to set criteria, right? Because we have ICD-10 codes that we have to attach a code to why we're seeing the patient. Well, how many of you have been to the doctor for PMS? I mean, one or two, maybe. Most patients, again, are not complaining of this, but when you have severe enough symptoms that it's bringing you to the doctor's office for treatment, then you need a way to code for it. So ACOG has given you a list of standards that they have to meet, criteria they have to meet for the diagnosis of PMS to be. So you have premenstrual symptoms and you have premenstrual syndrome, where it's actually affecting their daily life during that time. Okay. So the symptoms have to only occur within 5 days of the start of menses. They have to have occurred in 3 menstrual periods in a row. And then at least 1 affective and 1 somatic symptom have to be present. So it can't just be that they bloat and they have some pelvic pain and their breasts are tender. They also need to have anxiety, anger, aggression. People said, in their family said, please go to the doctor. Okay? Social withdrawal, like, I don't want to go, do we have to do that, things like that. So the next thing is so there's your symptoms. You have to have 1 of each, affective or mood and somatic. You also, these symptoms have to go away within 4 days of starting, obviously. Okay. If they're feeling like this all the time, it's something else. We have to make sure they're not taking anything exogenously into their system that are causing these. So medicines they're taking other hormones, natural hormones, synthetic hormones, using alcohol, using drugs, things like that. Rule that out. The symptoms themselves have to occur during 2 cycles prospectively. So then once you, to me that means once you've established the diagnosis, then they keep occurring down the road, okay? And then patients suffer, like missing work, because they need to lay at home and have a heating pad or that kind of stuff. It's affecting their school. You'll see teen girls with this. They don't want to go to school when they have their period. You know, what do I want to tell them? I mean, you know me. Suck it up, Buttercup. Did it kill you? No, go to school. My poor daughter is, you have to be actively vomiting or have a fever over 100.5 to miss school. And there is no, my tummy hurts, and I'm not going today. And my kids don't get sick, magically, wow. They're never sick. Thank goodness. And then, that's it, that's the last of it. So, a lot of women have PMS symptoms. It has to be affecting their life in some manner for us to label it as such PMS symptom, okay? When it's just PMS syndrome, or PMS, it's mostly going to be physical stuff, a little bit of minor mood stuff. It's not going to be major mood issues, okay? Conservative treatment, first thing, reassure them that it's in some ways normal. You know, tell them 75 to 80% of women experience these symptoms, especially in your young teenagers that don't really know what's normal yet. It's normal. Counsel them, tell them what they can do over the counter at home, stress management. Exercise actually has been shown to help reduce the symptoms. Mindfulness training, learn to process it and work through it. Stretching, yoga, things like that. Those thermacare patches, just slap a heating pad on and go. Those kind of things. You can do some just dietary type changes and things that will help reduce your caffeine and your chocolate. It's all the things you crave, it's kind of not good for it. Tobacco and alcohol. Actually increasing your complex carbohydrates abates some of the symptoms. And there's even been studies that have shown that. Decrease your salt. Why do we want to decrease salt? Because you're already swollen, right? And then trying to not overfill yourself, eat small frequent meals. If you eat a big greasy meal, you're going to just add to the bloat, that kind of thing. But what do you crave? Greasy, salty, chocolate. Yeah, chocolate for the day. Yeah. So there is some evidence to show that the 2 supplements that do help are calcium and magnesium. Calcium for bloating and discomfort, magnesium for the water retention. And then if you just are that awful, just lock yourself in the room for 4 days. Pharmacological treatment is not really exciting. And okay, listen, here's my slide. If Dr. Latassi gives you different information during Gyne Potpourri, take it and run with it. Okay? But for me, Aleve, NSAIDs, just NSAIDs, acetaminophen too, but I think NSAIDs work better because of the antiprostaglandin effect to actually act right on the muscle of the uterus. Okay? Spironolactone, if you're really swollen, you can just kind of give a water pill through that week if you need to. Again, here's bromocriptine back again. It's listed as a treatment for breast pain, but I would not use it unless their prolactin levels are high. And then there's this one herbal thing I could find was this Chinese herb that I looked in the literature and there's no evidence that it's really helpful. And I'm not going to try to pronounce it. What's interesting is Midol has acetaminophen in it, which I find interesting because it's not an NSAID. It's acetaminophen, caffeine, and some kind of piddly water pill, diuretic. But they market really, really well. So. I like this one as well. Why periods? Why can't Mother Nature just text her and be like, "What up, girl? You ain't pregnant. Have a baby."
That's awesome.
Of course, it's bringing it back to men because it's their problem too, right? They have a problem with it. Okay, so how do you diagnose PMDD? Did y'all talk about PMDD inside? Yeah, because it's in DSM-5. Oh, okay.
Also psych. And psych.
Oh, it's a thing. It is, I'm telling you guys, and it's a DSM-5 diagnosis now. I mean, it's in there. You guys will need to know the criteria here in a minute. We'll get to that. But the pathophys is fascinating. So it's not a lot of women, 5% of menstruating women, but it can be debilitating when patients have this. 15% of women with PMDD attempt suicide. It makes you that crazy, honestly. The mood symptoms here. So with PMS, the key was more somatic symptoms with a sprinkling of maybe a little bit of mood disturbance. This is mood. They may not have they may not bloat that much, they may not have maybe one mild somatic symptom, but it's the mood. That's the key here, okay? We'll see that on the criteria here in a minute. So what's interesting with PMDD is the symptoms are not depressive. It's not like I have the blues, I'm going to go lay in my bed and feel sorry for myself because I'm about to have a period. These symptoms are anger, aggression, impulse control, negative mood in the fact they want to poo-poo everything. Like, that is stupid. It makes, just irrational, extreme irritability, yelling at kids when they don't usually yell at their kids for the other weeks of the month. Suddenly they're like raging, angry mom. And a lot of it is directed at, guess who? The spouse or partner and the children, and it disrupts life. And it disrupts it every month. It's like, yay, we get to be normal for 3 weeks, then we get to do all this again in 1 month. So it gets to be extremely disruptive. The pathophysiology is really quite interesting because the research right now is like kind of starting, and how do we, it takes a long time for we have more women in medicine now, and now it's not just, here, take some benzos and go away. I mean, how many of your grandmothers were on benzos at some point in their life? I mean, what is the Latin base word for medical terminology for uterus? Hystera, like hysterical. She's got a uterus, so she's crazy. It comes every month and they get crazy. I mean, these terms were named that hundreds of years ago. So, I mean, everybody knew there was a problem. We're just now figuring out why, because we get smarter and smarter, finding receptors and molecules and metabolites, and, why are some women more sensitive than others? We do know that the sex steroids, estrogen and progesterone, influence neurotransmitter release. That's been proven, okay? We know they affect GABA. We know they affect serotonin. We know they affect dopamine. I am not a biochemist, and I am not qualified to go, now Dr. McNeil could have gone in deep depths on that, but you just need to know that it is a proven fact that those two sex steroids affect those neurotransmitters, okay? We know by studying humans that serotonin drops in the luteal phase. What's serotonin? You guys know this. It's your happy neurotransmitter. we know that estrogens increase serotonergic activity. So what happens when you have that sharp drop off of estrogen right there at the end of the late luteal phase? And then we know that GABA drops in the late luteal phase. So this is multifactorial. I mean, there are a lot of big hormone shifts going on in those last few days of that cycle. Oh, it's the chart again. So again, what do those hormones do in those last 5 days of the cycle? Especially the progesterone really just kind of takes a sharp dive down. Women are not just crazy. Okay. Something else we now know. Women with PMDD do not have higher levels of those hormones. They know that. It's not that they have more, so it's a sensitivity problem. They have the same levels, but it's a sensitivity to something. Okay, so they've studied it in twins, monozygotic twins, and there are similarities between monozygotic twins. What does that tell you in anything you study? Probably something going on. A genetic component that we're not smart enough to identify yet. Okay. So the recent literature is pointing to allopregnanolone. Okay. It's a metabolite of progesterone. And that's where the pathophysiology gets really weird, because allopregnanolone is a potent positive modulator of GABA, okay? But it depends on the level. So if it's present in really low levels, it does one thing. If it's present in really high levels, it does another thing, okay? Other positives, and so this is how you can kind of connect it in your brain. Other positive modulators of GABA are the other metabolite, pregnenolone, which isn't, as we know in PMDD, is not as big of an issue, but benzos, barbiturates, and alcohol. So those affect they activate GABA in the same manner. Okay, who has seen a bad angry drunk? Like, no impulse control, raging, irrational. I mean, it's probably those GABA receptors, okay? So just think, it's like your period drunk, you know? So, negative mood symptoms suggest irritability, poo-poo and everything, social withdrawal, I hate that girl, usually like her. Occur when allopregnanolone levels are similar to the normal levels in the luteal phase. Okay, so that we know those levels will cause that symptom. But women with PMDD have increased sensitivity to it. Okay, so it's normal to get a little crabby, but women that develop this true psychiatric problem in some manner, we don't know yet what receptor or interaction is going on, but we know that they are more sensitive to the allopregnanolone. Okay. And what's interesting is they found that they have decreased sensitivity to the diazepam, like the calming, calming effects of diazepam, and then pregnenolone, the other one. But then they're increased sensitivity to this other metabolite. Pretty interesting. Great pathophysiology question might come from one of these slides. So what are your criteria for diagnosing? So you're going to see a lot of ladies with PMS. So how do you identify the ones that are truly at risk for PMDD or have PMDD? So they got to have a minimum of 5 symptoms present. Okay, and this is DSM-5. Then we'll go over it in more detail here in a minute. But all the symptoms have to be present for the majority of cycles in the last 12 months. So you really can't even diagnose PMDD until you follow the patient for a year. Okay? So it might be PMS, you might be coding it PMS as you're following her over a 12-month period. But you need to have an established care with that patient for 12 months and follow her closely. Okay? There has to be functional impairment There has to be no other psychiatric disorder present. You should confirm the 5 symptoms by following her. And then you have to rule out other conditions, which you can do just with your history. Okay, so there is your breakdown in more detail. So what are those symptoms? So the symptoms have to occur in most cycles. They have, just like PMS, they have to occur in the week before menses. They have to improve within a few days of when she starts bleeding. And then they go away once she's completely off her period. They have to have at least one of category B. So they have to be labile, like a bipolar, like why is mom bipolar once a month? You know, they have to be very labile, they have to be irritable and angry, conflicts with people. So I mean, anybody ever experienced that with somebody who's like normally a pretty happy person, and then like it's that time and they like want to fight you, and it's irrational. I mean, everybody has probably had that experience at one time or another. They're not necessarily bipolar. They might be. They might be bipolar. But if it's happening just during the week before the period, it's this. They can have marked depressed moods, again, but more commonly it's the irritable, angry, agitated type. Okay? They might feel overwhelmed all of a sudden, might feel super stressed out and can't handle normally what would be a normal load for them they can handle, and all of a sudden they just want to throw in the towel, drive the car off a cliff because they can't handle it. They have to have at least one symptom from category C. So problems concentrating, low energy, everybody has, I mean, that's a lot of normal PMS symptoms. Sleep disturbance, again, there's feeling overwhelmed, and then look how tiny the physical symptoms are. It's just like that one little section there. And again, you don't even necessarily have to have the symptoms of PMS. You don't have to have bloat, weight gain, breast pain to be diagnosed with PMDD. It has to impair their function in society in some way, whether that be school absences, whether that be conflict at work, whether that be my husband left me because I'm such a bitch every month, marital problems, things like that. You have to rule out E and G. You have to rule out psych disorders of any other kind, and you have to rule out that they're not on drugs, not on alcohol. Duh. That they don't have brain on fire. Who's watched that yet? I've read it. It's really interesting. Yeah, read it, yeah. They don't have any other brain thing going on. Okay. And then you do have to confirm it. So you have to watch them with daily ratings. They have to document in a diary for at least 2 cycles so you can bring it back in and look at it and read, yep, there it is, 5 days before, there it is, you're back to normal. That kind of thing. So how do you treat it? Everybody just wants to put it around Prozac, right? But it works. It works, and this doesn't work the same way that it works for major depression, okay? There's something going on there, again, that we don't understand. It works that fast. Like you hear, like, that doesn't make any sense. How can they just put them on it when it's a placebo? Because they just put them on it, and they're okay for that week, and then they can stop taking it. It works that fast on the receptor that it's acting on. Okay, so it's not working the same way like in the brain where you have to build it up over 6 weeks or whatever, 4 to 6 weeks. This works really fast, and it works completely independent of any kind of antidepressant effect at all. So it doesn't make you not depressed, it calms that rage down, okay? Kind of brings you back to the center. The other thing you can do is just suppress the ovulation. So if it's a young girl that wants birth control, wants contraception, and also has PMDD, then that's a great thing. You can put her on birth control, make sure she doesn't ovulate. It should improve it. Studies are inconsistent on that. SSRIs work better, but if they want birth control, you try that first. And then, of course, you can completely shut down the whole axis, with your GnRH agonists. So you increase it so the feedback loop gets messed up. And you'll learn more about those from Dr. Latassi, and you'll learn more about those when they talk about endometriosis, because that's how you treat that. But it's not practical. I mean, you can't do that for somebody, you can't do that to somebody long term. So SSRIs are still the best for this. I like this picture in her light lit. Bright light therapies, did y'all talk about that inside? That is a real thing. I mean, who has seasonal affective stuff? I do. When that sun starts going down before I get home from work, I get cranky. I know it's going to happen. I actually, for this winter, I thought about getting one of those and putting it in my bathroom just to see if it helps. But I get a little bit of seasonal affective just because I like to be outside. You're not outside as much. You don't get fun, let's go do stuff in the snow. Winters here, you get cold, icy wind with like a sheet of ice to walk on. It's not like living in Colorado or something. Supplements that do help, again, back to the calcium, the vitamin B6, vitamin E, and magnesium. So there is some research to show that stuff does work. Again, if it's a milder patient and they're really motivated to do integrative type medicine, they want to try supplements first. That's the regimen I would start them on. And then acupuncture. I mean, you poke yourself in so many spots, you just forget everything else. I don't know how it works, but it does. It's been proven. So. All right. Questions? Okay, so this is like menstrual disorders, part 1. Laura Reinhardt's going to come do menstrual disorders, part 2. Dysmenorrhea, dysfunctional uterine bleeding, endometriosis, that kind of stuff on Thursday. So you guys have farm this afternoon. And then Good Shepherd in the morning, right? And then who's up tomorrow?
So is it just one lady and we're just all going to be in one room?
Oh.
Kind of like how we do our prostate?
But it's one at a time,
One at a time. And Professor Reggio and me both be there to help.
What's the dress code? Professional attire?
So professional for this, yeah.
Okay.
Professional for this?
Professional, because we'll have an SP. Anytime we're interacting with SPs, we want you guys dressed in professional attire. So, no short skirts for pelvic exams. And like I said, I don't know Dr. Gibson, how she does it, or I just talked about that doctor doing it, how you do pelvic exams in those high heels and short skirts, but I wouldn't recommend it for your first one. All right. You got to wear scrubs for this. Yeah, I mean, there won't be history taken or anything like that, but I think
I think that's why we all have that.
yeah.